So it's 7 o'clock, so we'll go ahead and get started. My name is Christina Ching. I'm a pediatric urologist at Nationwide Children's Hospital in Columbus, Ohio. I'd like to start off by thanking Hillary Kopp and UCSF for putting together this lecture series, and Michelle Lifto for her administrative help. Tonight I'm going to be talking about vesicoureteral reflux, and I called my presentation back to the basics because I'm hoping that while covering this vast topic to try and periodically pause to give us an opportunity to return to some basic principles that I personally try to use when I'm thinking about caring for these patients. I have no disclosures. The outline of my talk, I'm going to start first with talking about the anatomy of reflux. I'm going to talk about its diagnosis and the clinical implications of the different diagnostic studies, the challenges of their interpretation, the management of reflux, discussing the options and the different evidence for their use, as well as the AUA guidelines. And while AUA guidelines is under management, I'm actually going to go over them throughout the talk. So the definition of reflux is a backflow of urine from the bladder up into the kidney. It's defined by either being primary or secondary. Primary reflux is related to the congenital maldevelopment of the uterovesical junction, where there's a fundamental deficiency of the UVJ anti-reflux mechanism. This deficiency is thought to be related to the length of the ureteral tunnel, and specifically the ratio of the length of the ureteral tunnel to the ureteral diameter of being less than 5:1, as described by Pequin. And the length of the tunnel provides the muscle backing for the ureter, which then can be compressed when the bladder fills and thus prevents reflux. This is our first question. It's going to be an embryology question. I'm going to let you go ahead and read the questions and then answer. I will say that all these questions were taken from SASP practice questions. So hopefully they'll be relevant to when you're taking the in-service. So great. Majority did get it right. So reflux is a result of early budding that results in a lateral and high insertion in the bladder. Let's talk a little bit about the embryology of the ureteral development. So the ureteric bud, which comes from the metanephros, arises from the distalmost portion of the nephric or Wolffian duct, which is part of the mesonephros. And then the ureteric bud comes in contact with condensing blastema, which is the metanephric from the metanephric mesenchyme, and this then becomes the kidney. So if there's a deviation in the timing of this budding off the nephric duct, such as the bud branching early, it'll be incorporated in the UG sinus earlier, with migration of the ureteral opening to lateral high insertion in the bladder, with the potential for a short tunnel and thus reflux. Again, this is why you might see the ureteral orifice of a refluxing ureter in the lateral and cranial location. Conversely, if the bud comes off too late, it will result in a medial or caudate insertion of the ureter, such as what you'll see in an ectopic ureter. And this can really explain why you see reflux in the lower pole of a duplex kidney. Again, in the lower moiety of the kidney, you have the ureteric bud branching early. It'll be incorporated into the UG sinus early. It will start to migrate to a lateral and cranial location. There's also secondary reflux, which is really more a reflection of the issues with bladder storage and pressure rather than a defect of the UVJ. The UVJ is actually normal, but the anti-reflux mechanism is overwhelmed in this scenario. The rest of my talk really only focuses on primary reflux, but again, it's very important to consider whether reflux is primary or secondary. And so this leads us to our first stop sign for us to pause and go back to the basics. So when I'm looking at a patient with reflux, I tend to ask myself, the first question I ask myself is, what is the cause of reflux? And is there concern for secondary causes? This brings us to our next question. So great, everyone did really well on this one as well. It is spinal MRI. And when you're looking at how they're describing this patient, they talk about a large trabeculated bladder, incomplete bladder emptying, and so you're worried about a neurogenic bladder. So I'm really not that worried that the patient has primary reflux. I'm really worried that they have secondary reflux related to their neurogenic bladder. Again, also sort of a fine point is that this was a patient with an imperfect anus, and these patients can have spinal cord abnormalities. They should have a low threshold for evaluating their spine, and actually should probably be part of their workup. So the prevalence of reflux, it's seen in 30% of children with urinary tract infections compared to 17% without. It's present in up to 70% of infants with infection. There's a male preponderance if a patient's symptomatic. So in infants with dilated systems that are found to have reflux, the majority of them are male. And if a male presents later in life with a urinary tract infection, they're more likely to have reflux. Conversely, the majority of reflux is in older children. The majority of reflux that is in older children is in females, but probably that's just because older females tend to have infections more commonly, and so we're looking for it. There's also a racial predilection. So there's a 10 times decreased frequency of reflux in African American females as compared to Caucasians. Interestingly, this frequency equalizes after 10 years of age. And this is thought to demonstrate that there's really just a delayed maturation anti-reflux mechanism in Caucasians. We know that reflux is more common in younger patients, as you can see in this graph. And so the natural history of reflux is for it to actually spontaneously resolve over time. And this contributes to the nuances and controversies of its treatment. There is a genetic component of reflux. We see a prevalence in siblings of 32%. 100% of identical twins will have reflux, and 66% of offspring of children with reflux will have reflux. Believed to be inherited in an autosomal dominant fashion, and they're likely polygenetic mechanisms affecting various genes that regulate ureteral and kidney development. Those proteins are listed below. And also it's believed that there might be an issue with DNA copy number variations. So reflecting the importance of genetics, the AUA guidelines on reflux actually address how we should screen for reflux in siblings and the offspring of children with reflux. And so it's a recommendation by the AUA to evaluate for reflux through either VCUG or nuclear cystogram, which we'll talk about a little later, if that patient or if that sibling of a patient with reflux has an abnormal ultrasound or history of UTI. It's an option to look for the ultrasound in the first place. It's also an option just to observe those patients or those children who are siblings to patients with reflux. And then it's an option of how to screen offspring to just proceed as you would with the sibling of a patient with reflux. So beyond those of siblings, who else should be evaluated for reflux? This is really determined by how a patient presents. For those with a history of urinary tract infection, there are guidelines to help determine who should be screened. This includes the AAP guidelines, the NICE guidelines out of the UK, the AU ESPU guidelines. And so it really, as North American trainees, it's important to really know the AAP guidelines. These recommend in a child between 2 and 24 months of age who's had a febrile urinary tract infection, evaluating for reflux after the second febrile urinary tract infection, or if they have an abnormal renal ultrasound. The other presentation for reflux may be prenatal hydronephrosis. The risk of reflux in fetuses with antenatal hydronephrosis is about 9%. There are guidelines about screening children for reflux who have prenatal hydronephrosis. In the AUA guidelines on reflux, they recommend screening children who have high-grade hydronephrosis, defined as SFU grades 3 and 4. They have hydroureter or an abnormal bladder on ultrasound, or if they develop a urinary tract infection. And it's an option to either observe or evaluate those who have lower grades of hydronephrosis. And I'm going to refer you to a really nice lecture, two really nice lectures, both by Dr. Kern and Herndon, that are part of this UCF lecture series, and they went over the imaging in prenatal hydronephrosis and the imaging in reflux in very nice detail. So again, thinking back to the basics, if you're looking for reflux in a patient, it's important to ask yourself, why are you looking for reflux? And what is the clinical scenario that led to that evaluation? So the diagnosis of reflux is made by imaging, with the gold standard being direct cystography, either through a VCUG or a nuclear cystogram. In both, contrast is placed into the bladder via catheterization, and images are taken to look for signs of reflux. Just a little bit more about a nuclear cystogram, because for some of the trainees, you may be less familiar with this. So instead of using iodinated contrast material like you do in a VCUG, it uses a radioisotope. It actually uses technetium. The advantages are that there's less radiation than in a VCUG. It may also have greater sensitivity, as it provides continuous monitoring of the bladder as it fills and empties. The disadvantages are that there's no real anatomic determination. The classification of reflux using a nuclear cystogram is different than in a VCUG. It's actually just graded on 3 levels, basically mild, moderate, or severe, or 1, 2, 3. It can actually miss grade 1 because of the activity in the bladder, and so sometimes it's hard to see that distal ureter. Given its limitations, some favor performing a VCUG as the initial study to diagnose reflux and really reserve doing a nuclear cystogram for subsequent studies or follow-up. So going back to VCUG, we grade reflux on a VCUG according to the International Reflux Grading System. So the differences between grades 1 and 2 is looking at the contrast and whether it's in the ureter and the pelvis. Grade 3, you're starting to see some ureteral dilation and maybe some mild blunting of the fornices. In grade 4, you're starting to see some tortuosity of the ureter, and you're seeing blunting of the fornices. In grade 5, there's mass tortuosity of the ureter and loss of the papillary impressions. Grades 3 through 5 are called dilating reflux, and dilating reflux is important because it's associated with developing renal scarring. This is a systematic review that compared renal scarring in children with non-dilating or reflux grades 1 and 2 versus dilating reflux grades 3 through 5, and found that those with dilating reflux were more than 2 times likely to develop renal scarring. So given, there's actually a AAP protocol for performing VCUG that gives recommendations of performing a cyclic VCUG. It gives recommendations on the methods of performing the VCUG and the documentation of what the radiologist looks for and what we should be looking for in the read during the VCUG. And I draw your attention to looking at not just looking at the grade of reflux, but that also it's suggested or recommended to look at the onset of reflux, such as the bladder volume at which reflux occurred and the onset of reflux, if it's filling or voiding. So looking at these nuances of the VCG a bit more closely, bladder volume at the time of reflux is reflected in these images down low that show filling in a low volume versus at a higher volume in B. And this is a prognostic indicator of the spontaneous resolution of reflux, showing that those who reflux at higher bladder volumes have a higher rate of resolution. It also finds that bladder volume can predict the rate of breakthrough infections, with reflux at a lower volume associated with an increased risk of breakthrough febrile urinary tract infections, and this was independent of VUR grade. Another important aspect of the VCG is the timing of reflux. Did it happen at filling versus voiding? And actually finding that this difference can predict the spontaneous resolution of reflux as well. In this study, they actually compared the timing of reflux and looked at it if it determined who needed surgery versus who had spontaneous resolution of their reflux. And they found that of those patients who had reflux on filling, significantly more underwent surgery than spontaneously resolved, as compared to those who had reflux at voiding, significantly more had spontaneous resolution as compared to those who underwent surgery. So thus, reflux during voiding was independently associated with a greater rate of spontaneous resolution. Other predictors to try and improve the use of VCUG include the distal ureteral diameter ratio. This is a measurement of the largest ureteral diameter in the pelvis that you can measure on a VCUG, and it's normalized or divided by the distance between the bottom of L1 and the top of L3. And this is felt to be an objective measurement of the UVG anatomy. And the investigators who have promoted this is out of the University of Iowa, suggest that this can reduce the subjectivity of the International Reflux Grading System. They found that UDR correlates with the grade of reflux, and that it can predict the spontaneous resolution of reflux. They found that UDR had a larger effect than the grade on predicting failure of VUR resolution. They also felt that UDR can found that UDR predicts clinical outcome, and that the UDR is greater in those undergoing surgery and greater in those with breakthrough febrile urinary tract infections. And this was independent of grade. Another tool to improve how to interpret a VCG and use it to predict outcome is the VUR index. This is a validated tool for, again, predicting VUR resolution. It's a 1 to 6 point scale. It's an individualized risk-based approach using clinical factors and radiography. And the authors, this is out of Atlanta, they found that VUR index can predict spontaneous resolution and also predict breakthrough febrile urinary tract infections with an increased risk for breakthrough febrile urinary tract infections with higher VUR index number. And this was independent of VUR grade, and they found that actually the VUR index had an even better accuracy than the UDR. So two other direct measures of reflux that I want to mention briefly are the PIC cystogram and ultrasonic cystography. PIC cystogram is the positional installation of contrast, and it's used to detect occult reflux. So it's usually used if a child's having recurrent febrile urinary tract infections, but has a normal VCUG. What happens to perform this is that you instill contrast through like a pediatric cystoscope positioned at the ureteral orifice while a patient's anesthetized, and then you look for reflux on fluoroscopy. It's somewhat controversial. Dr. Kern did a really nice review of ultrasonic cystography, but basically it uses microspheres placed in the bladder and detects them on renal ultrasound to look for VUR. Again, I direct you to her lecture if you want to learn more. So we know that ultrasound cannot diagnose reflux, and there are concerns with its ability to determine the risk of reflux. There's been not found to be a significant correlation between a normal ultrasound and absence of reflux. And the sensitivity of an ultrasound in predicting reflux in a child after a first urinary tract infection is really quite low. In addition, clinically significant reflux can be missed, as demonstrated by Suzanne and Matthews in their study. So to improve the sensitivity of ultrasounds, investigators have looked at uroepithelial thickening, which is a finding on the ultrasound as seen on the slide. It's a hypoechoic rim within the renal pelvic wall that's delineated on each side by a thin hyperechoic line. And uroepithelial thickening has been found to be a significant independent predictor of high-grade reflux in children after their first febrile urinary tract infection. It's also been found to be significantly associated with high-grade reflux in children with prenatal hydronephrosis, increasing both the sensitivity and specificity of an ultrasound for high-grade reflux, and especially when it was used in conjunction with hydroureter, renal duplication, and renal dysmorphia, which were themselves found to be predictive of high-grade reflux. And you can see uroepithelial thickening alone had a sensitivity of 94%. So urine biomarkers are an emerging frontier in the setting of reflux. They would be ideal if they could differentiate between low and high risk populations. They're non-invasive, so they're really an area of a lot of interest. Currently, classic biomarkers such as serum creatinines, cystatin Cs, and clearly radiologic findings haven't been able to detect loss of function before it's significantly advanced. There have been some urine biomarkers of renal scarring that have been found in children with febrile urinary tract infections, but they're still quite experimental. So deciding to treat or not to treat. Well, it's important to ask, why do we care about reflux? Because answering this will help us understand the potential treatments. So again, this is an opportunity to stop for a second and think, how and why was reflux discovered? And what is the outcome of discovering that reflux? So the clinical implications of reflux are very important, and we'll help answer some of that. So reflux facilitates pyelonephritis. Reflux by itself is not a cause of infection. And why do we care about reflux? We care about reflux because we care about scarring. And we know that scarring is associated with pyelonephritis, and that reflux is also a risk factor for renal scarring. And why do we care about scarring? Well, we care about scarring because of the sequelae, such as hypertension and end-stage renal disease. So scarring occurs because fibrous tissue has replaced normal tissue destroyed by injury or disease. You can see on this DMSA where there's signs of scarring noted by deficient radiotracer uptake due to abnormal tissue. That results in those wedge-shaped defects that you see with the green arrows. This can be seen histologically on, and I should say this is a mouse kidney, but this is a mouse model of pyelonephritis, and you can see histologically why you might see those defects on the DMSA, because all the normal architecture of the kidney has been lost in that wedge-shaped form. So we also know that scarring with reflux needs bacteria due to pig models done by Ransley and Risden. We also know that with increasing number of infections, the rate of scarring also increases. In this post-hoc analysis, they found that the odds of renal scarring after the second urinary tract infection, febrile urinary tract infection, were almost 12 times greater than that after the first febrile urinary tract infection. We know that the risk of renal scarring is inversely proportional to age, with the greatest risk being within the first year of life. But even patients less than 4 years of age are more prone to developing scarring after a single urinary tract infection. The anatomy of itself also may dictate risk of scarring, with the morphology of the individual renal papilla predisposing to scarring. A compound papilla, which is really sort of a fused papilla, has that flattened or concave surface with the papillary ducts at a right angle, so that when there's a rise in intracalyceal pressure, the backflow can actually go right into, into the papilla and lead to damage. That's in contrast to a convex papilla on the right, which has more of a cone-shaped surface, and the ducts are more obliquely entering at the surface, and thus they can close when you have backflow of urine to for protecting the kidney. There has which is seen on the VCUG, such as pilotubular backflow, results in the areas of atrophic, or correlates with the areas of atrophic pyelonephritic scarring. So this leads us to our next question. I think I have to give you a minute to read the question because the poll didn't give us enough room to actually give the full history. So I'm going to give you a second, and actually I'll read it out loud, but then when the poll pops up, you'll see it's truncated. So a 2-year-old girl has a febrile urinary tract infection. An ultrasound is normal, but a VCUG demonstrates left grade 4 reflux. There's a compound upper pole calyx and simple calyces throughout the rest of the kidney. A DMSA scan of the left kidney at 1 week and 9 months after the infection would most likely show So it was a little bit mixed, but it's actually the third answer. So the reason that she's going to have an actual upper pole defect at the time of the infection is because she has that compound calyx. And so she's more at risk for that area to be where she's going to get pyelonephritis. So that will lead to a defect even at the time of her having the infection. And then it's also going to be the location of the scar. So then you'll see the defect on a delayed DMSA. So as a mechanism to identify those at risk for renal scarring, there's something called the top-down approach to diagnosing reflux. This looks for renal involvement at the time of infection to identify those in whom we might want to look for reflux. It uses a DMSA, which is the gold standard for imaging renal parenchyma. And it's been found that acute DMSA scan abnormalities during an infection have a high sensitivity and predictive value of diagnosing dilating reflux later. So stated sort of otherwise, the likelihood of dilating reflux is low when the DMSA is negative. This suggests that VCUG may only be indicated in a child who has DMSA abnormalities. There has been a large meta-analysis to review the accuracy of DMSA compared to renal ultrasound in diagnosing reflux and high-grade reflux. And these authors found that for detecting reflux overall, renal bladder ultrasounds has a pretty low sensitivity, which we already knew, but also DMSA has a really low specificity. And this holds true even with trying to detect high-grade reflux. So they concluded that neither ultrasound or DMSA is accurate enough to detect reflux of all grades. So some of the challenges in diagnosing renal scarring is that renal dysplasia can look like renal scarring. And this can represent a challenge for the specificity of the DMSA. So going back to the embryology of reflux, we know the interaction between the ureteric bud and metanephric blastema is important. So with known abnormalities in ureteral budding related to reflux, it follows that there can be maldevelopment of the kidney, and particularly in high-grade reflux. And unfortunately, differentiating between congenital versus acquired abnormalities can be difficult. So now turning to the management of reflux. So historically, we treated the finding, but the utility of aggressive management of all primary reflux has come into question, and this has resulted in a more selective or a more individualized approach. According to the AUA guidelines on reflux, the goals of reflux management are to prevent the occurrence of febrile urinary tract infection, prevent renal injury, such as scarring, minimize morbidity, and minimize morbidity of treatment and follow-up. So again, going back, thinking when you're getting ready, should I treat a patient, or what should I treat how should I treat a patient? You want to first think about how and why was reflux discovered, and then look at the patient themselves and their characteristics and maybe some of the risk factors for developing another febrile infection or for developing scarring. And then importantly, you want to engage the family in shared decision-making. And this is actually so important that the AUA guidelines make this a standard. So there are 3 different levels of statements in the guidelines. There's a standard, a recommendation, and an option. And standard is the highest. It's unanimously agreed upon by the panel members. So this is one of the few standards in the guidelines. But what they say is that there should be a discussion of the treatment of reflux with the family and patient. And this should include understanding adherence with the care plan, the determination of parental concerns, and the accommodation of parental preferences. So in the initial step in management of reflux, it's important to identify and treat bowel and bladder dysfunction. And again, this is another one of the standards in the AUA guidelines on reflux that say that symptoms of bowel and bladder dysfunction should be sought in the initial evaluation. And they define bowel and bladder dysfunction as urinary frequency and urgency, prolonged voiding intervals, daytime wetting, perineal and penile pain, holding maneuvers, and constipation. We know that bowel and bladder dysfunction, as well also known as dysfunctional elimination syndrome, is associated with poor reflux outcome. In this study by Koff, they found that just under half of individuals with primary reflux had signs of DES, or dysfunctional elimination syndrome, or bowel bladder dysfunction, and that 82% of those patients went on to have breakthrough urinary tract infections and need reimplantation, as compared to 18% of patients with reflux who did not have DES. And they also found that DES adversely affected surgical outcomes, with all children who had an adverse outcome after their reimplant, including persistence of reflux or recurrence of reflux. They all had DES. This leads to our next question. So great, almost all, pretty good, 91%. So really, it's important. It's just a really important message to make sure that you always evaluate for bowel and bladder dysfunction and address it. So the first line of treatment has classically been prophylactic antibiotics, and the thought is that you want to keep the urine sterile while you're waiting for reflux to resolve. And this is predicated on that high rate of spontaneous resolution. It's also predicated on the thought that sterile reflux is benign. and that the goal is to really temporize morbidity and complications without surgical intervention. So we know that reflux resolves over time, and thus reflux resolves with age. There are some limitations to this, where children diagnosed with reflux at older age are thus less likely to resolve. So it's not necessarily that any patient, anytime, as long as you give them time, it will resolve. It is also dependent on the age of diagnosis. But why we think it does resolve in some of the younger kids with time is that they just need remodeling of the UVJ with time, and that they just need stabilization of their bladder dynamics. The traditional period of observation for a young child diagnosed has been 5 years, because that's believed to be when there's the greatest completion of UVJ remodeling. We also knew that reflux resolution is inversely proportional to the initial grade, with those with lower grades having a higher rate of resolution as compared to those with higher grades having a lower rate of resolution. There's a nomogram that was developed after a review of a large number of children, 2,462. And this nomogram involves the following factors, with the factors grayed out that predict resolution. So I would encourage you to look at this if you're interested, and maybe make it part of your practice. So given that reflux tends to resolve with time, there's the thought of, while waiting for the reflux to resolve, should we use an antibiotic or not? With the benefits of not using an antibiotic, obviously avoiding using an antibiotic, and their potential pitfalls like allergies, adverse responses, cost, and also bacterial resistance. But then also some of the benefits of antibiotics being, well, is it going to reduce the chance of a subsequent febrile urinary tract infection and reduce renal scarring? And to answer some of this, we do have randomized controlled trials, which I'd like to go over now. So this is the first randomized controlled trial of antibiotic prophylaxis or not in those with acute pyelonephritis with or without reflux. It was a multi-institutional study out of Florida, Chile, and Spain. For this study, they only included children with lower grades 1 through 3 reflux, and they followed the patients for a year with a DMSA every 6 months. And they found that antibiotic prophylaxis among patients with reflux does not decrease the overall incidence of recurrent urinary tract infections, the rate of pyelonephritis, or the formation of scars. But looking through the paper, I actually never saw that they did a statistical analysis of those outcomes, but I think some of that is just because the numbers of children with reflux in the prophylactic versus no prophylactic groups were so low, and the events were so low, they just couldn't really do an analysis, but it basically was not different if you look at the numbers. This is the next randomized control trial, and this was a double-blinded trial. This was out of Australia, and it's called the PREVENT trial that you can see at the bottom, PRIVENT, just if you've heard of it. But this actually looked at antibiotics versus placebo in children with a prior symptomatic infection and followed them for a year. This included children with both reflux or without. About 42% of the children had reflux. And they found that overall antibiotic prophylaxis decreased the risk of recurrent urinary tract infections and febrile urinary tract infections. But when they did a subgroup analysis on just those children with reflux getting prophylaxis or not, they were not significantly different, as you can see in the plot up top. What they did find is that more commonly those on antibiotics had a UTI resistant to Bactrim. The next study only looks at children with dilating reflux, so all these children had reflux. This is out of Sweden. It's the Swedish reflux trial. It was a randomized control trial of children getting either antibiotic prophylaxis, undergoing endoscopic treatment, or surveillance, and they followed patients for 2 years. They found that recurrent febrile urinary tract infections were significantly different between those on surveillance versus on antibiotic prophylaxis, but only in girls. They also found that new renal scarring was significantly different amongst all the groups, with 8 children developing new scars in those in surveillance as compared to none in those who were on antibiotic prophylaxis. They also found that new renal scarring was significantly associated with febrile recurrence. And then the last study I want to talk about is the RIVER trial, which hopefully at this point most have at least heard of. So the RIVER trial was done in the United States. RIVER stands for Randomized Intervention for the Management of Vesicoureteral Reflux Study. This was a randomized controlled trial, double-blinded, looking at antibiotics versus placebo control in children after the first or second urinary tract infection, and they followed them for 2 years. They included children, all the children had reflux, and it could be grade 1 through 4. They just excluded children with grade 5. Children underwent annual DMSA scans, and their primary outcome was the development of recurrent febrile or symptomatic infections. They found overall that antibiotics reduced the recurrence of infection by 50%, but they didn't find that prophylaxis affected renal scarring. But the RIVER trial really wasn't designed to address renal scarring as a primary endpoint, and there are some thoughts as to why they didn't see this effect due to some low baseline prevalence of scarring and the early treatment of recurrent infections that was just a natural result of being part of the study. So in order to delve a little further into why preventing a recurrent urinary tract infection did not result in less renal scarring, this is a paper that did a sub-analysis of the relationship between recurrent urinary tract infections, new renal scarring, and antibiotic prophylaxis, with looking at if new renal scarring occurred after a recurrent urinary tract infection and seeing the effect of antibiotic prophylaxis on that. They found that recurrent urinary tract infections were independently associated with new renal scarring, and they did find a higher risk of recurrent urinary tract infection associated new renal scarring in those who were on placebo compared to those on antibiotic prophylaxis after they adjusted also for certain patient considerations. So to review how this all fits into the AUA guidelines on reflux, the guidelines recommend for children less than a year of age that if they've had a history of febrile urinary tract infection, they should be on continuous antibiotic prophylaxis. And even if they haven't had a history of a febrile urinary tract infection, if they have high-grade reflux, again, that reflux that can be related to scarring, that they should be on continuous antibiotic prophylaxis. It's an option for even those who don't have a history of febrile urinary tract infection but have lower grades of reflux to also be on continuous antibiotic prophylaxis. And then in children with reflux who are greater than a year of age, again, recommendation, if they have BBD, make sure you treat that before thinking of any sort of interventions. And if they have BBD and reflux, it is recommended that they be on antibiotic prophylaxis. Whereas if they don't have BBD, but just have the reflux, it is an option to be on prophylaxis, or it's an option to observe those patients. So again, thinking back to the basics. So thinking about treatments, we know that reflux tends to resolve spontaneously and it's related to age and grade, and that the premise of antibiotic use during watchful waiting is to maintain urine sterility. But we also know that antibiotics result in a reduction in urinary tract infections or recurrent urinary tract infections if they've had a prior febrile urinary tract infection, and maybe it also reduces the risk of renal scarring. But also to make sure that we really target DES and BBD in the evaluation of these patients and the treatment of these patients. So once it's been decided on using medical therapy in the form of an antibiotic treatment, the next debate is, do we use antibiotics as the medical therapy or do we proceed with surgery? And to help try and figure this out, there are some randomized controlled trials that compare these two different treatment modalities. So there's the International Reflux Study that randomized children with high-grade reflux, again, reflux grades 3 to 5, to antibiotics prophylaxis versus open surgery. And they found the incidence of urinary tract infections was not significantly different between the two groups. They did find, though, that pyelonephritis was more common in those on antibiotic prophylaxis compared to those who underwent surgery, but there was no difference in scar formation. And then there's also the Birmingham Reflux Study, which also randomized children with high-grade reflux to antibiotic prophylaxis versus open surgery. This is a study out of the UK, whereas the International Reflux Study, these results, it actually was a combined study out of both Europe and the US, but these results for what I just described were for the US arm. But the Birmingham Reflux Study is out of the UK. And they found the same instance of urinary tract infections and new renal scarring between the two groups. So one concern people have with not repairing reflux is what risk this might have for women during pregnancy. And so I direct you to the Journal of Pediatric Urology Mythbusters from last year. And on a side note, if you've never read these, this is a great series and I'd really encourage you to check them out. But they examined if persistent reflux in older girls should be considered an indication for surgical correction. They found an overall high rate of or incidence of UTI and pyelonephritis among pregnant women with a history of reflux, but little data to suggest that persistent reflux is itself a risk factor for infection during pregnancy. There is strong evidence of increased maternal and fetal morbidity when the mother has renal scarring, and so perhaps that population specifically requires very close monitoring during pregnancy. But so the verdict of this mythbuster was that the current evidence is insufficient to support the routine anti-reflux surgery in girls with the sole purpose of decreasing complications of future pregnancy. So when you're thinking about who needs surgery, it's important to find to basically group those with the lowest tolerance of having another infection. And those include patients with multiple episodes of pyelonephritis, patients with breakthrough infections, and those who have scarring already. And I'd also add probably a group that is intolerant of medical therapy. There are the two different types of surgical interventions can be done endoscopic or with an endoscopic injection or reimplantation. That's a topic for a whole other lecture, so I'm not going to go into the differences or compare really the two. But I am going to give you an SASP question about the anatomy during a reimplant, so I'm going to let you answer that. So the answer is the femoral nerve, and it's just the femoral nerve runs in the psoas muscle. So maybe just a quick anatomy review during these COVID times. So to put together these last concepts with the AUA reflux guidelines, the guidelines state for any child who has reflux greater than a year of age, it's an option to go to surgery, and it can be either open or endoscopic. In a child with breakthrough urinary tract infections with reflux on continuous antibiotic prophylaxis, the guidelines recommend that if a patient has a febrile breakthrough infection while on antibiotic prophylaxis, that they should be considered for surgery with a curative intent. It's an option if a patient on continuous antibiotic prophylaxis has a single breakthrough, febrile breakthrough urinary tract infection with no known renal issues, that you can just change the antibiotics to an alternative antibiotic. And just for completeness in this group of patients, it's also a recommendation if patients aren't receiving continuous antibiotic prophylaxis and they have a urinary tract infection, that you initiate antibiotic prophylaxis. And that can be either if they have a febrile infection. If they don't have a febrile infection, it's an option also as well to put them on antibiotics. So the last thing I'd like to briefly discuss is the parental position in treating reflux. There have been several studies evaluating parental thoughts and preferences for reflux treatment. There was an online community survey that found that parents thought effectiveness was the most important, with cost and cosmesis being the least. There was a study looking at questioning parents using questionnaire, questioning them, and they were all parents of children with reflux. And those parents chose initially for treatment and using antibiotic prophylaxis, but only if the duration was relatively short. But if the duration was going to be a long time, then they tended to choose definitive correction. And there are actually two studies. These are out of DC Children's. So the first study found that the surgical corrections that parents chose was primarily endoscopy over open. But then in a follow-up study, they found that that has changed to open over endoscopy. In the Swedish reflux trial, which again, if you remember, is the randomized control trial of children with high-grade reflux, again, the reflux that can lead to scarring, that were randomized to either antibiotics, endoscopic intervention, or surveillance. They found that there was no difference in parental satisfaction or preference between randomized groups. But interestingly, they found that antibiotic prophylaxis, or parents of children who had been on antibiotic prophylaxis, were more often than others to would have chosen another treatment option if they had been given a choice. And lastly, I'll end with a study that's actually senior authored by Dr. Kopp, where they interviewed parents about their experience with treatments for reflux. And they found that parental preferences regarding risks and benefits varied. with the chief concerns being whether the method decreases the risk of infection, has an acceptable efficacy rate, and aligns itself with the capabilities of the family. So hopefully this talk has given you some direction for caring for patients with reflux, or maybe not, maybe it's left us even more confused. But then again, we can always go back to the basics. So the meaning of an isolated finding of reflux is unclear. So I'd encourage you to always sort of question how and why it was found. We do know that reflux in the face of infection risks renal damage. The diagnosis for reflux is made on imaging, although the etiology of scarring is sometimes unclear. And we know that reflux should be treated if there are concerns of renal damage. But the treatment options also should really take into consideration patient and family goals. So at this point, I should have said at the beginning, I'm going to take questions. I wanted to just get through the presentation, and then I'll take questions at the end. So we're at the end, so I'm happy to take questions. I have seen some things pop up. Let me start looking here. So question, do I use any of the reflux grading tools routinely in your practice? So I should be using them more is the short answer. This was actually a really great opportunity for me to review some of the tools that are out there, and I should be using them more. That issue of timing of reflux on the VCUG and the bladder volume at reflux is a really important point, and we have to be sure that our radiologists are also on board with giving us that information. And so that is actually a really important, we have had recent discussions because that is not consistently always reported at our institution, and we've actually had some discussions with radiology about trying to do that more, because I think that is that I would say is one of the most important things that I do use. When do you recommend stopping continuous antibiotic prophylaxis for patients with reflux? Oh, well, I was given a couple of options. The short answer and the evasive answer is it depends. It really depends on the patient and why we found the reflux again, potentially how sick they were, how young they were, and what other maybe risk factors they have, and also really involves a very thorough discussion with the family, and also my sense of, kind of what the family capabilities are. So I'm going to be pretty invasive about that. Why are we so concerned? So basically the short answer too is I don't have a hard cutoff for that. Why are we so concerned about renal scarring? But as you said, it's difficult to differentiate from renal dysplasia, and one can not prevent dysplasia. So I agree. Dysplasia is dysplasia. That's not something that is really, the horse is out of the barn at that point. So that's not an issue that can be prevented. What you don't want is new damage or new renal scarring, which is what high-grade reflux has been associated with. Do you follow the top-down method, and when do you order the DMSA after febrile urinary tract infection? How far after the episode? So I personally don't follow the top-down method. It wasn't how I was trained. It's not used where I practice now. It's just, I think, to some degree, DMSAs are a great study in theory, but they're practically a hard study to obtain. First of all, there were issues with getting the radiotracer, and then it's also just a difficult study. So when to order the DMSA after a febrile urinary tract infection episode, it really depends on what you're looking at or what you're looking for. Are you looking for renal involvement during the infection? And if so, then you'd want to order it at least within a month, ideally maybe a week or two. But then if you're looking for long-term damage, then that's when you get a delayed DMSA, and that's about 4 to 6 months. What is the better treatment in VUR, laparoscopic or endoscopic, and why? So I would say that is a whole other can of worms to discuss, and I maybe at some point, I can give a lecture on the different treatment modalities in a comparison, like a literature review of the comparison of treatment modalities. It's a really good question, but probably, again, it's its own topic for a lecture. How important is it to give antibiotic prophylaxis before CUMS? Is that maybe a VCUG or micturition MCUG? I'm not totally sure. For the person who asked about the antibiotic prophylaxis before CUMS, if you can spell out that that abbreviation so that I know. I'm thinking you might be asking about a VCUG, but I'm not 100% sure. Sometimes internationally, a VCUG is called different things. So personally, the issue about antibiotic prophylaxis around VCUG, I'd actually have to look. I didn't look specifically at if there's any current literature about that. I personally, I mean, a lot of those kids who are getting a VCUG, they may have been, we try and do them while they're on therapy for their symptomatic infection anyway, because then they're kind of covered. Hydronephrosis on ultrasound after urinary tract infection. Okay, so there's hydronephrosis on ultrasound after an infection. Repeat cultures keep coming back positive despite antibiotics and asymptomatic. At what point can the VCUG be performed? So I'm assuming that this question is sort of asking, it sounds like someone's getting, there's recurrent and positive, like almost asymptomatic bacteria or maybe contamination, but they have hydronephrosis on ultrasound and they have had a UTI. So I guess I'd probably have to know a little bit more about the patient, like how bad hydronephrosis are we talking about? I mean, is it just some splitting of the renal pelvis? What was that urinary tract infection? Was it a febrile urinary tract infection? Because then there's got to be a reason that there's been checks of urine afterwards. So I don't know that I have enough information to really make a good assessment of what I would do in this patient. So I'm happy for the person who asked that. If you give a little bit more information or want to, you know, clarify that, I can try and readdress it. What agent for endoscopic treatment? We use deflux. So sorry, I guess I'm realizing that you guys can't read the questions and I can. So the full question was, what agent for endoscopic treatment do you use? We use deflux. Is there any age when you would stop looking for vesicoureteral reflux with a VCUG in an older child with recurrent urinary tract infections? So the short answer is no. I mean, if a child's having repeated infections, if they haven't had a VCUG, I would do a VCUG. I wonder if the question is, I'm just a little bit confused about the question. So if, though they've had VCUGs that are negative, but they're still getting recurrent and particularly febrile urinary tract infections, number one, you can think about getting a nuclear scan, because again, it may be a little bit more sensitive. And sometimes if you actually do it sort of around the time of the infection, because really maybe it's during the infection that there's an issue with the anti-reflux mechanism. So you can consider that. That's where, again, though, you might consider a PIC cystogram, which again may be somewhat controversial for me to say that. But if that's what the question is, that they've had negative VCUGs, but they're getting repeated infections, when would you stop? Just keep repeating the VCUG? I mean, if VCUG is negative, I wouldn't just keep repeating it. I would think about another utility of trying to evaluate. And sometimes in those patients too, so one of the benefits of a PIC cystogram is that the patient's anesthetized, you're in there with your cystoscope, so you can actually go ahead and inject with like an endoscopic, like, you know, deflux at the time. And so it's at times diagnostic, but then therapeutic. For open surgery, which technique do you recommend? Do you prefer laparoscopy? So again, that is a whole other discussion. Okay, so someone clarified that CUMS is a VCUG. So let me go back. So that was, again, the importance of antibiotic prophylaxis before VCUG. Honestly, I want to give an educated response to that. So I'd have to look and see what some of the updated literature, if there have been some updated studies about that. But generally our patients kind of are on antibiotics because we're getting the VCUG while they're during the course of their treatment. When do you decide to do a second VCUG? And is the nuclear cystogram useful to decide a new treatment? So second VCUG, I'm not totally sure if it's asking, do I get a second VCUG in terms of follow-up? Or what? The AUA guidelines recommend, I think it's like a year to 2 years of follow-up VCUG, and it can be tailored to longer depending on the patient clinical situation. And that's just for like surveillance. Is the nuclear cystogram useful to decide a new treatment? I'm not really sure what that's asking in terms of, I'm not really sure what that's asking. 1-year-old boy with breakthrough urinary tract infections, bilateral grade 1 reflux on VCUG. What do you think? Prophylactic antibiotics. So again, I mean, I think some considerations would be, is the patient circumcised or not, looking at their, making sure that he's not constipated, and really talking with the family. So when you say breakthrough febrile urinary tract infections, is he already on an antibiotic? Because then, if he is already on an antibiotic and he's had a breakthrough, again, depending on what his kidneys look like, if this is the first breakthrough infection, you could change the antibiotic, or you could proceed with surgery. And again, going now into sort of the difference between endoscopy and surgery for some of the low-grade reflux, and he's only 1 year, you could think of endoscopy. What is the surgical management with this patient? This must be referring to a prior. This is referring, I think, to a prior question, but the prior question was asking about which is better for reflux, laparoscopy, or endoscopy. So I'm sorry, what is your surgical management with this patient? I don't know what you're referring to. Do you use endoscopic treatment for grade 5 reflux? So again, whole other discussion, but there have been some really good studies that I would direct you to out of Sweden, looking at downgrading reflux using endoscopy from grade 5 to lower grade reflux. And I would encourage you to follow those. I'm just looking at the time because I'm seeing, I just want to be respectful of the time. If yes, what time after surgery? Oh gosh, some of these questions are, I don't know the order because this is a question that sounds like it was referring to another question. I'm not sure that I know what this is referring to. Is it necessary to do a VCUG as a control after surgery? So again, the AUA guidelines for endoscopy actually recommend that you do a post endoscopic VCUG, and it's an option to do a VCUG after open surgery. For open surgeries, which techniques do you prefer? Again, I'm going to reserve some of the treatment, like comparisons and discussions of surgery versus endoscopy, to another subsequent lecture. Do you use video urodynamics in secondary reflux for follow-up? Of course, if I'm worried about secondary reflux, I would absolutely get a urodynamic study. And then again, someone was asking about VCG post-endoscopic treatment. So again, the AUA guidelines do recommend 1 month after endoscopy. Okay, I actually think that is the end of the questions that I'm seeing. I'm so sorry because I do think there were some questions that I was not completely clear about. So if you have any questions or concerns, oh, and I should put up the last slide to show the show for the survey. But please feel free to email me if you would like to discuss more. Thank you so much, and again, I really appreciate being able to participate in this lecture series.